Hi all, my name is Scott Bragg, an assistant professor with MUSC. I've prepared a short presentation on inpatient diabetes management in a little different presentation format called Pecha Kucha, where 20 slides are presented for 20 seconds each. The objectives for this talk will be recall the goals of therapy with DKA and HHS, identify appropriate treatment strategies for diabetics not DKA or HHS, and individualize inpatient management for specific patients, all in 400 seconds. When admitting a patient for DKA or HHS, order via the DKA order set. This will coordinate urgent labs, schedule an EKG and chest x-ray, make the patient NPO, start insulin and fluids, synchronize electrolyte replacement, and consult diabetes education. To differentiate DKA from HHS, blood sugars are higher in HHS and there is a larger water deficit. DKA will have abnormalities like blood ketones causing an acidotic pH and low bicarb. Both are treated the same with IV fluids, electrolytes, and an insulin drip. The acute goals for DKA and HHS are a stable blood pressure and adequate urine output to prevent the most common causes of death, infection, and MI. To transition to sub-Q, sugars must be below 200, the anion gap must normalize, and the patient must tolerate oral intake. Fluids are the most important intervention early on with DKA or HHS. They will help prevent shock and maintain adequate urine output. When blood sugars fall to less than 200 milligrams per deciliter, change normal saline to D5 and half normal saline to prevent hypoglycemia while the acidosis corrects. An insulin drip is started with a 0.1 units per kilogram bolus. Then the drip is started at 0.1 units per kilogram per hour. Blood sugars are checked hourly, and the drip is adjusted until sugars fall by 50 to 100 milligrams per deciliter per hour. The insulin protocol is designed to reverse the acidosis or hyperosmolar state without causing excessive hypoglycemia. Once two sugars fall below 250, the drip is more slowly titrated. The insulin drip is stopped if blood sugars fall below 150. Potassium should be added to fluids while on the insulin drip because of the rapid intracellular shift on insulin. If K falls below 3.2, stop the drip and follow the electrolyte replacement protocol. Since potassium is regulated by magnesium, replete mag with values less than 1.8. Give 15 millimoles of phosphorus over 3 hours with values less than 2. Bicarbonate is controversial in DKA. Only give 50 milliequivalents if pH is less than 6.9. When given at a pH of 6.9 to 7.1, it may paradoxically worsen the acidosis. To stop an insulin drip, make sure blood sugars are less than 200, oral intake is tolerated, and your anion gap is closed. At Trident, a basal order for 0.2 units per kilogram is given sub-Q, and the drip is stopped in 2 hours. If sugars are controlled on someone's home regimen, resume that regimen. For insulin-naive patients, start a total daily dose of 0.5 to 0.8 units per kilogram per day. This should be split 50-50 with basal and bolus. Remember that the total daily bolus is split between each meal. For non-emergency diabetes management, generally continue outpatient regimens. Hold metformin only with IV contrast or illness-causing lactate production like sepsis or renal failure. On all other regimens, watch for changes in kidney function and adjust or hold accordingly. When starting insulin in non-DKA patients, consider an initial basal dose of 0.2 units per kilogram per day and monitor fasting sugars for dose titrations. If needing mealtime coverage, add 5 units with the largest meal and add coverage to other meals gradually. Guidelines recommend against sole use of sliding scale insulin in the hospital. Generally only used with steroid hyperglycemia and when predicting insulin requirements. Beware of hypoglycemia, particularly with high doses and when scheduled at bedtime. When using sliding scale insulin to calculate basal needs, count up sliding scale used in 24 hours and add approximately 50% the next day. Never send someone out on sliding scale insulin for mealtime coverage. Always schedule a mealtime dose or a specific carb count ratio. Inpatient targets vary depending on the patient. For ICU patients, guidelines recommend 140 to 180. Cardiac surgery patients have mixed data, showing benefit with 90 to 120 and 120 to 180. No studies exist for non-critically ill diabetics to refer to outpatient goals. Insulin pumps remain an inpatient diabetes management option at Trident. It's okay to use if a patient is well controlled at home and clinically stable. The patient must sign the release of responsibility form and work closely with their provider to manage sugars. For making inpatient diabetes educator consults at Trident, be sure to order in the glycemic order set or as a separate consult to diabetes education. One of our diabetes educators will provide patient education, identify barriers for patient, and document their findings and recommendations. Hopefully this presentation provides a primer for inpatient diabetes management. I hope that you can now recall the goals of therapy with DKA and HHS, identify appropriate treatment strategies for diabetics not DKA and HHS, and individualized inpatient management for specific patients.